Hi, this is Brian Kim. I want to share with you case number 201 in the Best Way to Do Cataract Surgery series. This is a chalky white Catarock. You're going to see Trypan blue placement and how I do it, and then terminal chop and cross chop, and then methodical lens disassembly for better outcomes. Again, you want to use mechanical forces to fracture the lens and less ultrasonic energy, and as a result, the corneal endothelium is going to be happier, which results in clearer corneas postoperatively. You can see how dense and white this cataract is. I'm using a cotton tip to steady the eye. You can see this is probably the left eye. This patient has a little bit of a Bell's reflex. I use a corneal marker to help me center inside the rexus. Make a paracentesis incision first on the right side and then the left side, making sure I'm flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some intracameral air, and then the Trypan blue. You can see I'm not vigorously pushing Trypan blue. I've heard of people pushing it really aggressively, and all that does is just push it into the vitreous space. That makes no sense. It doesn't belong there. So drip it on the anterior capsule and then just kind of sweep it around. Just like, if you had a big dollop of paint on your canvas and then you take your hand and just kind of wipe it around all around. That's exactly what you're trying to do. Don't push it into the vitreous space. This is dispersive viscoelastic, pushing the bubble out as well as the Trypan blue. And this is a triplanar corneal incision. I make a vertical groove, control the eye with the cannula. Go into the deep part of the groove, tunnel, and then I enter. And the cannula is helping me to control the eye with that maneuver. And then throughout these other parts of the case as well. This is the sharp tip Haldi-Perkar forceps. This patient, again, has a strong Bell's reflex. I'm using the cannula with the Orlock technique to turn the eye down, which is towards the left. Puncture the center, pulling down, grabbing the right side of the tear, going around circumferentially. You can see this patient's really fighting me. There's corneal stria that's happening because of it, but I'm able to control the eye and pull it down with the Orlock technique using the cannula. Once I get to that part, you see how I came out. Once I get to this part, the forceps can allow me to turn the eye towards the left because that's the action that the forceps is going. So it's really not necessary to keep that cannula in. Burp the viscoelastic out, get those pieces of the capsule out as well. And this is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally. But I see some bubbles, so I go out again, and then I start again. Go under the rexus edge. Very carefully and gingerly, point the tip down. Of course, I can't see the wave. I'm going to lift the lens up and then decompress very gently here. Oftentimes with these really dense lenses, the lens has really been disassociated from the capsular bag on its own anyways. Go ahead and spin the lens, which happens really nicely and easily there. Adjusting the sleeve. Lifting the incision, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. Because this is a dense lens, I've switched to the dense lens mode, and I'm going to sculpt. Go ahead and sculpt the trough. And you don't have to go beyond the rexus edge. And remember, you want to make sure that you sculpt without pushing down on the lens too much. And you don't have to go all the way down to the posterior capsule. That's the beauty of terminal chop. You don't have to try to get all the way down. Remember, when you do it the traditional stop and chop, you want to go solo close to the posterior capsule, which is really honestly risky, and I don't know why we're taught to do it that way. And then you try to crack from the top, which actually makes no sense because you're trying to crack from the top, but the adhesion point is on the other side, on the posterior capsule. So you get that Pac-Man effect. Again, not sure why we were ever taught that way. I guess we didn't know any better. And so this is a much better way to get directly at the posterior adhesion point. you fracture from the terminal side. And how do you do that? You're able to get it from the equatorial side, from the fornix. Again, in the traditional horizontal chop technique, place a chopper out to the equator. Remember, those lamella are concentric. And so when you get to the terminal side on that contralateral side, those concentric lamellar fibers are propagating all the way through the posterior lens material. And so you're getting a through and through fracture point all the way. You'll never have a posterior plate phenomenon ever again if you perform the technique this way. Again, due to the concept and the principles of having concentric lamellar fibers, when you fracture from the terminal side, it fractures all the way through the posterior side, and you'll never have a posterior plate phenomenon this way. I turn that lens again. I place the chopper around the right heminucleus, pulling it centrally toward the phaco tip, and that is a cross-chop maneuver. Using some vacuum to grab that fragment up, crushing the lens into smaller and smaller pieces, and then emulsifying the lens piece. Again, very carefully fracturing the lens, making sure I'm hugging the lens with the chopper, fracturing it. And once you've fractured it into smaller enough pieces, you can just use judicious amounts of ultrasonic energy and vacuum, and then remove the lens pieces. Again, I'm using a cross-chop maneuver to get around that second quadrant, crushing it very easily and bisecting it. Again, using the instruments to control the lens pieces, crushing the lens pieces into smaller pieces, and then emulsifying the lens pieces. All of the action is started with the chopper. This is really the crux of this technique. By placing the chopper around the lens, you can hook it from the peripheral lens. You can pull the lens pieces up out of the bag. You have exquisite control. And since the phaco tip can apply opposing forces to the chopper, I'm able to bisect the lens without ultrasonic energy or vacuum. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip, and fracturing the lens against the phaco tip. Doing the same maneuver around that third quadrant, and then very carefully and gently fracturing the lens in half, grabbing that fragment with some vacuum, holding it, and then getting the chopper around it, crushing the lens into smaller and smaller pieces, and then emulsifying the lens pieces. Again, this is a rather dense lens, but I'm just taking my time, chipping away, as we say, chipping away little by little by little. And as you do this, eventually you'll take this entire giant cataract lens out. But remember, what you don't want to do is just go pedal to the metal. You know, you get impatient, you just want to move on. This case is taking too long, you're getting frustrated, and you want to go pedal to metal. I mean, is that really the best thing to do? You know, I try to do the surgery, every single surgery, as if the patient's my sister or my brother. I want to make sure I provide them the best results so that, you know, I can sleep at night and make sure I know that I did the very best that I can. You know, if I've done the best that I can, but the patient ends up with a problem, well, I'll still feel bad about it, but at least I know in my heart of hearts that I didn't cut any corners when I did the surgery. So that's why I do this surgery like this. Again, it might be painful to watch, because I'm crushing the lens into smaller and smaller and smaller pieces. Some people would say, just eat the piece and get on with it. But again, because I try to adhere to that principle, I want to be as gentle as possible. I want to do the surgery like they're my family member. And, you know, honestly, I trust myself more than anyone else with a family member. I have done eye surgery on my family members versus asking other people to do it. And that's because I know that I will do the very, very best for them. And, you know, if something happens, I will have to live with that. But the good news is I will know in my heart of hearts that I did everything I could, the very best that I can for the patient And again, if I extrapolate that from a family member and treat every patient like they're my family member, then I know in my heart of hearts, I've done everything I can for them, at least the best that I could for the patient. So you see all the lenses out. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. You can see that the cortex is rather sparse in this eye, again, because it is a dense cataract, and some of that lens material came out with the cataract removal. There's still some fine remnants, so I switched to polish mode, polishing underneath the rhexis edge. You can see there's quite a bit of posterior capsule fibrosis as well. And those are tough cases because when you have posterior capsule fibrosis, that lens material is rather adherent to the bag. Pulsing the subincisional capsule fornix with the BSS, you can see there's so much stuff coming out. And so again, when you can't see it, you don't know it's there. But by using the cannula to pulse into the subincisional capsule fornix, it's able to liberate the lens material. Pushing some cohesive viscoelastic to fill the capsular bag, but making sure I turn off the infusion, the fluid from the INA handpiece. And then I'm sweeping with the polisher, first on the left side and then the right side. And as you know, whenever I'm dealing with these dense lenses, I always assume that there's zonulopathy as well. And so I'm going to put a 3-piece lens in and I have to widen the incision with my blade. I take the sweep out and switch to the cohesive viscoelastic because as I push the lens in, it will cause some OVD to come out. So I'm able to push more viscoelastic to inflate the bag. I go in with the leading haptic pointed to the left and then dial the optic in, turning my hand and pronating it to let the optic come out flat. And then I use a Maltzman to dial the trailing haptic into the bag. Go in with irrigation off, go underneath the lens, removing the viscoelastic from within the bag, repositing the optic back down, using the INA handpiece to turn the lens, going to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a chalky white Catarock. I use Trypan blue, but I don't vigorously over push the Trypan blue. I see some people just like vigorously pushing Trypan blue. And if you do it that way and you overinflate the anterior chamber, then what you're going to do is you're going to push all that stuff into the vitreous space, which again, it doesn't really need to be there. You just worry about toxicity, but you also, again, those who depend upon that red reflex, you won't have a red reflex. So why would you do that? So again, push an air bubble in and then very carefully drip the Trypan blue on the anterior capsule surface. And then you saw terminal chop, cross chop. Again, I'm able to fracture the lens, not from the top because that would cause a Pac-Man effect if you have a posterior plate. I'm able to fracture from the terminal side, and because of the concentric lamellar fibers, I'm able to fracture the most posterior lens material from the equatorial side, terminal side, and this fracture point can propagate through and through, and again, protects you from developing a posterior plate phenomenon. Again, you saw multiple cross-chop maneuvers to break down the lens into smaller and smaller pieces and then emulsify the lens piece. Again, these patients, in my experience, tend to have much clearer corneas post-op day 1 versus traditional cataract surgery techniques. And again, this is because there's less endothelial trauma. Again, using ultrasonic energy can and does cause endothelial damage. Mechanical fracturing does not. And this is why I feel this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.